in that order.
Mr. Chairman?
Mayor Heller?
Thank you.
You got it.
Thank you for this hearing. I want to thank those that are witnesses for being with us today, and I want to especially thank Senator Tester, because I know this is an issue that's important to him, an issue that's important to Montana. And it is unfortunate that Montana leads us in this statistic, but the issue is that the Nevada's right behind them. And question that I continue to ask myself is what makes Montana and Nevada unique? And Mr. Kuntz, I'll start with you as to why we see the stress in the areas of Montana and Nevada maybe a little more unique than the rest of the country.
Senator Heller, it's a great question, and I'll tell you that if I had the perfect answer for that, I would probably be making a lot more money. But I will tell you that just to see what is there is we do have higher access to lethal means in our state for the most part. When you're suicidal, the closer you are to committing suicide, I mean, is very real. We also have a lot of veterans per capita in our communities, and I think that that's important. One of the things that's a little bit different about our suicide trends, and I don't know if it's the same for Nevada, is we have more older veterans that are killing themselves, and I think that there's national trends saying that it's younger. But if you look at Montana, that age 30 to 65 white males is when we're losing them, and maybe it's just that we have a lot of people in that population group. But I think it's it's also an issue of lack of care. We have no psychiatric residency program in our state, and I know that a lot of Nevada rural communities struggle too. So I think it's a number of different factors, and we've got to tackle them one at a time.
I really do appreciate your comments. We had Secretary Shulkin in the state just a month or so ago, and he expressed his efforts and trying to tackle this particular problem. We have hospitals both north end and the south end of the state. We have a number of clinics that have been opened recently because of the efforts and the work of the Secretary and the VA, and it's appreciated. Let me ask you, Mr. Bryan, they have a resiliency program in Israel that maybe we've already discussed this, where they try to get this on the front end instead of the back end, where they actually train their soldiers, both male and females, of trying to avoid some of the stressful situations they may find themselves in and train them for them. Are we doing the same thing here in our country?
I would say in general, yes, in the sense that if you look at military training in general, a lot of it is designed to foster resiliency, how to endure difficult, aversive situations, perform under pressure, manage stress, etc. Where we have not had much success over the past decade or so is when we try to develop new resiliency programs that take more of a classroom format, wherein we bring in outside experts who then teach or train sometimes trainers within the units or resiliency experts within the units who are then supposed to go and teach these concepts and skills to others within the unit. And there have been a number of barriers to that, but unfortunately some of the research that's been done on some of the larger resiliency programs, such as comprehensive soldier fitness, have yielded no benefit. We have seen some promise, however, in other resiliency methods. One that has garnered the greatest promise so far is a program developed by the Army called BattleMind that was shown to prevent or reduce PTSD symptoms. A small degree, it wasn't large, but it was a small and noticeable degree amongst those who had the greatest and most intense levels of combat exposure while deployed, which, if you think about it, in many ways makes sense. Where we found the effect were the ones who probably needed it the most and the ones who had the highest level of trauma exposure while deployed. And so we have a couple of threads of evidence suggesting that certain approaches might help to reduce or prevent this, at least reduce the severity of PTSD. However, we have not been able to large-scale implement and further study those different strategies.
Is there any family training? Not just the veteran themselves, but actual family training so that they can identify some of these issues prior and prepared to help that veteran?
Right. There are a number of programs that have been created. There's none that sort of rises above the top. Where a lot of the family training programs, and this actually is very common, the peer issue that you mentioned before, a lot of the programs tend to take more of a, here's a bunch of signs and symptoms of this health condition and now refer someone to a mental health professional. But what we lack is, what do the family members do? So if a veteran is struggling with PTSD and does not want to go to treatment, or there's a 2-week wait, what are you supposed to do in the meantime? And we don't currently have any programs training that. Now, newer research, for instance, the crisis response plan that I mentioned before, this is something we have been teaching to family members. We've been teaching to peer specialists. We've been teaching the non-healthcare providers in the community who are closest to the veteran in need to not only recognize when they might need help, but also what to do about it, in doing things that have been scientifically shown to prevent suicidal behavior and reduce PTSD.
Mr. Bryan, thank you, and I want to thank all of our panelists. Mr. Chairman, thank you. I want to thank the Secretary who's in the audience with us today for his commitment and coming out to the state of Nevada and expressing his concerns on these particular issues, because it does make a difference, and we need to figure this out and make that kind of difference. Mr. Chairman, thank you very much for the time.
Thank you, Senator Heller.